So we'll give another 1 or 2 minutes to 8:02 or so to allow people to sign on. I have 1 minute before the hour. Good morning, Wad. Thank you for joining us, or good afternoon, good evening. Wad is an incoming PGY4 geriatric medicine resident from Saudi Arabia. So a warm welcome to Dr. Binafif. Thank you. We read good morning in the chat. Good morning, Mercedes. Thanks for joining.
Good morning.
So Farid is going to present first, if that's okay. Good morning, Liv. Thanks for joining. Hi, Peter.
Morning.
Good morning, Carolyn. Thanks for joining. Hi, Barb. Hi, Gary.
Good morning.
We'll give it 1 more minute to allow others to sign on.
Dr. Gendal, can I just test that you can hear me smoothly, clearly?
Yeah,
Okay.
very well. There we go. Okay, good morning and welcome to the last Journal Club session of this academic year. We'll start with land acknowledgement, which I've been using to highlight some historical facts to avoid a performative nature of the routine land acknowledgement. So we recognize that many Indigenous nations have long-standing relationships with the land upon which the work of the University of Toronto's Department of Medicine is conducted. We acknowledge our presence on the traditional territory of many Indigenous nations. Land acknowledgements are only a starting point for larger conversations. Section 35 of the Constitution Act of 1982 declares that Aboriginal peoples, the legal term used for Indigenous peoples in Canada, include Indian First Nations, Inuit, and Métis peoples. In Canada, the term Indian has specific legal contexts. The document governing the federal government's relationship with First Nations people is called the Indian Act. As part of the Indian Act, the federal government maintains an Indian register that is an official record of all First Nations people who are recognized as status Indians. Before the 1980s, the most popular term for a person of First Nations heritage in Canada was Indian. In 1980, hundreds of chiefs met in Ottawa and used First Nations for the first time in their Declaration of the First Nations. In 1982, the National Indian Brotherhood became the Assembly of First Nations. They are a political voice for First Nations peoples in Canada. Symbolically, the term elevates First Nations to the status of first among equals as founding nations of Canada. It is reflective of the sovereign nature of many communities and the ongoing quest for self-determination and self-government. The term is not used by Indigenous peoples outside of Canada. So today we have two PGY4, exceptional PGY4 residents presenting. The first and short presentation will be delivered by Dr. Farid Medleg. He will present the efficacy data on respiratory syncytial virus prefusion F protein vaccine in older adults. Farid, I welcome you to share your slides.
Thank you. I just want to make sure everybody can see that I've shared. Okay, great. So as mentioned, I'll be discussing the data that led to the Arexvy acceptance in Canada and the US for use in older adults. And so the title of the research paper is called the Respiratory Syncytial Virus Prefusion F Protein Vaccine in Older Adults. So there's no conflicts of interest to disclose. The objectives of today's talk is simply to review the burden of RSV infections in older adults and then to go over the study in question and then talk about a couple future directions. What I won't be covering today is data on the immunogenicity of RSV vaccines, and that's specifically how it affects the serum and antibody titers of people after they take them. And I also won't be reviewing the safety profiles. Hopefully that's something that can come up later now that the vaccine has been approved. And fingers crossed that somebody takes this up in a different journal club. So in terms of RSV infections in older adults, considering adults over the age of 60 in industrialized nations, a meta-analysis was done in 2019 and showed 5.2 million cases of acute respiratory tract infections in people aged over 60. 470,000 of those resulted in hospitalizations, and 33,000 of that number resulted in deaths. What's not always discussed is that the RSV burden among healthy older adults and those with comorbidities is similar to the numbers in influenza. However, up until 2020, we didn't actually have good, effective, and cheap testing, and so the burden went underappreciated. 40% of all RSV-associated hospitalizations occurred in patients over the age of 65 years, and so the burden among older adults is disproportionately carried. Reinfections are common throughout life due to a short-term and or incomplete immunity response, depending on age and comorbidity status. And so this brings us to this study, which sought to create a vaccine much in the same spirit as COVID and influenza, given the fact that this virus evolves year on year and reinfection actually is a very high issue. And so the study question is this vaccine against RSV-related lower respiratory tract disease efficacious in adults aged 60 years and older? The population study was men and women over the age of 60, primarily in community dwelling populations. There was a small representation in long-term care, but it was less than 5%. The treatment was a single dose of the Arexvy vaccine, and the control group was a saline placebo injected into the same area, usually the deltoid. Objectives measured were RSV-related lower respiratory tract disease, subsequently confirmed by PCR, and then there were secondary outcomes looking at RSV infection, severe RSV disease, and RSV-related lower tract disease subdivided by RSV subtype, age, comorbidities, etc. And the reason why I distinguish disease and infection is because it's the number of signs and symptoms that qualifies you for each group. And so they wanted to see how severe the infection was and did analysis for each subgroup. Patients that were excluded were ones that were currently or previously enrolled in another RSV vaccine trial. So you cannot have received any type of RSV vaccine in the past. If you had an immunosuppressive or immunodeficient condition, you were excluded. And if you had chronic illness that was serious or unstable. And so people with heart disease, diabetes, respiratory disease were included if those disease processes were well controlled. This is an ongoing trial, and so they're in their third RSV season now. I'll be presenting data from the first two RSV seasons. It's a double-blind phase 3 trial spanning 17 countries over 5 continents. Primary efficacy analysis included only cases that were reviewed by an external adjudication committee that was not involved in study design. And so everybody that had symptoms that qualified for RSV and then confirmed by PCR was then sent to an external adjudication committee to confirm the presence of those symptoms qualify for counting in positive cases. And so you can see the randomization here. What I'd like to draw your eyes down to is these boxes, who were the ones included in the primary efficacy analysis. The numbers are virtually identical. So this kind of reflects the one-to-one randomization that was done. You can see demographic results and sort of baseline medical results for each group. We won't go through each line, but essentially the groups analyzed were identical in terms of demographics, race, geographic location, frailty status, which was determined by a walk speed test, and the existence of comorbidities. Now, onto the results. I would like to draw your attention to the rightmost column that is showing vaccine efficacy. And essentially, vaccine efficacy is the difference in vaccine incidence between the placebo group and the vaccine group. And so what they do is they count the number of cases, raw cases, that you can see in the second column, and calculate this per 1,000 participant years. And then they divide these two totals. And you can see that there are 5.8 cases inside the placebo group and 1 case inside the control group per 1,000 patient years, leading to a vaccine efficacy of 82.6%. And this efficacy is pretty much maintained through every subgroup analysis, except for adults aged 80 and over. Moving on to frailty status and RSV subtype. Again, the vaccine efficacy is maintained except for adults who are considered frail. But the results bear out in fit adults and pre-frail adults as well, with the confidence interval frequently over 40 or 50%, or the lower end of the confidence interval. And so the discussion mainly centers around efficacy. And so overall, a single dose of the Arexvy vaccine had an efficacy of 82.6% against RSV-related lower respiratory tract disease among adults aged 60 years or older during one RSV season. The efficacy was 94% against severe RSV-related lower respiratory tract disease, and 71% against what they term acute respiratory tract infection, which is a smaller number of signs and symptoms. Older adults with comorbidities were well represented in this study. Frail older adults and those living in long-term care were not well represented. And I think that's the source of why the confidence intervals were not as strong in those subgroups. There was equal protection against A and B subtypes, and efficacy throughout the median follow-up of 6.7 months was maintained and displayed. So this study was actually published in February of 2023. And this is the data that led to the approval by the FDA for use in older adults in May of that same year. And subsequent to that, in August of 2023, Arexvy was then approved in Canada for use, again, very quickly after this study was published. Here is a table of results from their second season. And so the top group looked at adults randomized to only having received that first dose. And the bottom table is the group that was randomized to receiving a subsequent dose. And while the vaccine efficacy numbers are lower, between 50 and 75%, they still are quite high and don't cross the zero line. And so the conclusion from this preliminary results from the second year of testing is that one vaccine dose can maintain immunogenicity and efficacy 2 years later. In terms of the critical appraisal, this is actually a study with a low risk of bias. Patient assignments were randomized. Groups were almost identical at the start of the trial. Aside from the allocated treatments, all groups were treated equally. All patients who entered the trial were accounted for and even analyzed in an intention to treat approach. And measures were objective. And clinicians were kept blind, except for the adjudication committee who was reviewing the symptoms after patients were assigned and confirmed to have a diagnosis. So is this study generalizable to our patient population? I would say for the most part, yes. And I would say that the lack of efficacy seen in frail older adults and adults over the age of 80 is due to the small numbers in those groups and not necessarily because the vaccine is not efficacious in these groups. Older adults with comorbidities were included, but only if they were considered stable. And so patients in the acute setting, I believe, don't have good representation. And so I do think that this needs further study going forward. This study is strong because of its large sample size. So 25,000 patients randomized equally 1-to-1 to 2 groups. They were diverse, and vaccine efficacy was demonstrated across 2 RSV seasons. I already mentioned not all the older adults were well represented. And there is one caveat here that the study took place during the peak of the COVID pandemic. And so RSV spread was reduced because of all the isolation measures and mask wearing and hand washing that was going on. And the timing of the RSV season actually began earlier because of this. And so the authors admitted that this is a potentially limiting factor and started their count months before the normal RSV season is known to begin. So they thought that this accounted for this limitation, but they can't completely be sure because this is an unprecedented event. So in summary, a single RSV Arexvy dose was efficacious against lower respiratory tract disease, acute infection, and severe lower respiratory tract disease. And I guess this brings us to the question, is this study practice changing? And I guess that actually depends on whether vaccine counseling is part of your practice right now. I think the purpose of this study and my sort of hidden intent with choosing this study was to alert people that we actually have a good tool against RSV infection now. And that if you've made recommendations to older adults about the flu vaccine, the COVID vaccine, regular vaccine schedules, that you can now start to include RSV vaccination inside of that discussion. The Arexvy vaccine is already available at Shoppers Drug Mart and Rexall, and so this is something that's easily accessible for older adults. Thank you very much.
Thank you very much, Farid, as usual, for an excellent and very clear presentation. I'll ask you kindly to stop sharing your slides so we can see the gallery. And I'll open it up to questions either in the chat or with the raise hand function. Michael, your hand is up. Go ahead.
Yeah, that was a great presentation. And having received the vaccine, I was actually shocked when I found that I had to pay for it. And having been along with Gary many years ago on the DQTC committee, which determines what drugs and medications are funded, I can't understand why this was turned down for funding, whereas the influenza vaccine and COVID vaccine, all those are covered for funding. Is there any way to find out what the basis of the determination was that it wasn't accepted for funding?
I did not see any of this on the Health Canada website and the NACI website. My sort of very educated guess is that it just hasn't received as much media coverage and sort of political pressure as the other things. It's very popular to discuss COVID, and the flu has been around, the flu vaccine has been around for a long time. I think in time we'll see that happen, but I agree that's a severe barrier for people. So
yeah.
And similarly, Carol writes in the chat, is the cost of the vaccine not a limiting factor? Yeah. And can you, Michael, how much did you pay for the vaccine?
If I recall, it was something like $200. I mean, that's a lot of money.
And thank you, Chris, our pharmacist here at Sunnybrook. It's $300 if not eligible.
Oh, $300, okay.
Yeah. Go ahead, Gary.
Thanks, Farid, for the excellent presentation. The lack of funding may be timing, because I think the results of this came out very close to the fall vaccination seasons. So I'm not sure whether they've actually had adequate time to review the data, Michael. I don't know for certain, but I think that may be a factor. I was going to ask Farid, because perhaps you have a sunnier disposition than me, but the concern with the over 80 and frail not showing efficacy, and what we know about impact of perhaps frailty and aging on the immune system, and in some irony, those are the groups perhaps that we feel are most vulnerable, that we'd rush to get the vaccine like this for them. And I'm currently feeling a bit uncertain as to whether those groups are actually going to derive the benefit, and whether they may need some type of adjuvant to increase the immunogenicity or something else? So I'm wondering if you might want to talk about that a little bit.
It's a great question, and I wish I had more time to go into the immunogenicity of vaccines in general. From data with the RSV trials themselves, as well as COVID, we know that the immune reaction lessens over time. And I mean, older adults have a lower immunogenicity, even though they do show greater immunogenicity than placebo, of course. And so I think it speaks to your point in the sense that, like, is the data in this trial due to the small numbers, or is it due to actually lower immunogenicity? I don't have a good answer, but I think that we should look at that. If you compare it to studies that have attempted to look at the effectiveness as well as the efficacy of flu vaccines, the numbers are much lower. So estimated vaccine efficacy for the flu vaccine is something like 18 to 45% on average among older adults. And so given the fact that the numbers for people up to the age of 79 were shown to be as high as 70, 89%, my estimate is that the results in this study are not significant for that age group because of the low numbers, but certainly immunogenicity trials with larger numbers of patients is warranted.
Okay, thank you. And Barry writes maybe 2 doses for those vulnerable groups. And perhaps the final question for the interest of time, can you mention or can you say something about the tolerability? I know there was concern with some of the other vaccines like zoster, the 2-dose regimen, and the difficulty with tolerability. Would older adults follow through with the 2nd dose? Is there any concern with tolerability with this vaccine?
So in this particular study, severe adverse reactions were no different between the placebo group and the treatment group. There was higher reactivity, local reactivity in the treatment group, but those reactions were deemed to be like local skin reactions, pain, and things like that, and like very transient flu-like symptoms immediately after the vaccine. And so the conclusion from the authors here was that it would be tolerable in older adults, but there are studies looking at this specifically, and there is a study that was published in late 2023 that looked at this. So preliminary data suggests yes, but more data necessary.
Thank you very much, Farid. For the interest of time, we will have to move on, but further comments are encouraged in the chat box. Our second presentation today comes from Dr. Mercedes Lupo, our incoming lead resident, or one of our incoming lead residents, and she will present a prospective cohort study on antidepressant use in relation to dementia risk, cognitive decline, and brain atrophy. Mercedes, please share your slides and feel free to begin. Thank you.
Thank you. Okay.
I have your slides too, if you'd like.
Oh, I have them here. Just want to make sure I have the right view.
I see.
So here, is this the presenter view or the just the
We see
slide?
the presenter view.
Okay. Oh, just lost it just a moment. So this should be,
Yep, perfect.
okay, great. So today I'll be talking about looking at antidepressant use and risk of dementia, and whether this risk is maybe not such a risk, according to the study that we'll look at. No conflicts of interest to declare. We'll look a bit at the background context for this. We'll introduce the study that we'll be reviewing, and then go through a critical appraisal and come up with some bottom lines. If we center this around a case of a 66-year-old woman seen for CGA, doesn't have any cognitive concerns at that time, has a past medical history that's pretty routine, including a history of depression that's controlled on paroxetine for the past 10 years, with a smoking history, but no alcohol history. And she asks about whether there's any risk of cognitive decline with her antidepressant, if there's any risk of dementia. So the question arises of whether you should stop or change your paroxetine on that basis. And so when we think about depression and antidepressants and dementia, it's a bit of a muddled picture. So depression is commonly seen in older adults. Up to 20% of older adults in Canada have symptoms of depression. And these rates increase up to 40% for those in hospitals and long-term care homes. According to the Canadian Institute for Health Information data, the use of antidepressants was 23.4% in Canadian older adults in 2021 and had increased particularly during the COVID-19 pandemic. In 2019, this was 22.3%. And older adults are recommended to remain on antidepressants for at least 6 to 9 months after the start of benefit, according to the Canadian Coalition for Seniors Mental Health recommendation. And so the 2020 Lancet Commission noted depression as a potential modifiable risk factor for dementia. They cited a meta-analysis of 32 studies with over 62,000 participants and follow-up ranging from 2 to 17 years, finding that a depressive episode was a risk factor for dementia with a pooled effect size of 2. This schematic here on the slide was published in Nature Reviews Neurology in 2011 to depict the complex relationship between depression and risk of dementia. And so at, for example, the bottom left, we see vascular disease. So the vascular depression hypothesis states that cerebrovascular disease predisposes to geriatric depressive syndromes through frontostriatal abnormalities. And studies have reported that vascular lesions can contribute to depression later in life. Whether vascular disease contributes to depression or results from depression remains to be fully elucidated, as each condition is associated with an increased risk of developing the other. And then at the top left, we see increased risk of glucocorticoids through activation of the HPA axis, and increased cortisol production with depression is linked to hippocampal atrophy as a proposed mechanism of linking depression with dementia. It's also proposed that depression increases amyloid beta production by a stress response associated with depression and glucocorticoid levels. And that's been primarily suggested by results from animal models. And then these factors, along with pro-inflammatory changes and alterations in nerve growth factors, contribute to the potential pathway from depression to dementia. To complicate matters, depression can also occur in the prodromal phase of dementia. So proposed mechanisms are that it can occur as a psychological reaction to cognitive decline or as a shared neurobiological mechanism between depression and dementia, potentially as an early symptom of beta amyloid deposition and neurodegeneration. In support of this, it's been observed that depression with first onset in later years is more likely to be associated with cognitive impairment, and increased depressive symptoms have been noted in individuals with normal cognition and increased cerebral beta amyloid burden. The Lancet Commission also cites a 14-year-long longitudinal study of almost 5,000 cognitively healthy men between 71 and 89, finding that depression was associated with a 1.5-time incidence of dementia, developing within the first 5 years of the depression. And then when it comes to treatment, antidepressant use, there's conflicting evidence on whether or not antidepressants increase the risk of dementia. The question of whether these medications would increase the risk of dementia arises from their potential anticholinergic and vascular effects. For example, a 2023 systematic review and meta-analyses in the Journal of Clinical Medicine included 6 studies with a wide range of sample sizes, anywhere from about 700 to 141,000, and a median length of follow-up of 5 years. The pooled relative risk was 1.21, with the 95% confidence interval not crossing 1, showing significant increased risk of dementia in older adults with depression. However, they cited common limitations such as The heterogeneity across the studies included an inability to account for depression progression underlying the risk of dementia, and thus a confounding by indication. So overall, the methodology of these studies is usually challenged due to two reasons. So confounding by indication, where depression is a risk factor for dementia, and so antidepressant use in patients with depressive symptoms might link their use to depression, and reverse causality, so whereby prodromal symptoms of neurodegeneration lead to antidepressant use. The study that I'll talk about tried to address this using brain MRIs to look at change and instrumental variable analyses, looking at whether slowed metabolism of antidepressants increased risk of dementia to better capture causality. So this brings us to the study that I wanted to present. It was published in April of 2024 in Alzheimer's and Dementia by Van Hoff et al. In Rotterdam, Netherlands. And basically, they looked at participants who were dementia-free over the age of 60 with a mean age of 70.6 years in the cognitive analyses. But when they actually looked at MRI scans of the brain, they included individuals as young as 45 years old to account for a potentially long preclinical phase of neurodegenerative disease. And they looked at ever use of antidepressant medication to never use in the initial analyses, but then further stratified that, which I'll show you in some of the results tables, but basically looked at former versus current use and defined exposure as duration of use and cumulative defined daily dose. The main outcomes they were looking at were dementia risk, cognitive change, brain volume changes. So the participants were extracted from the Rotterdam study, which as a background is an ongoing population cohort, population-based cohort study that has been running since 1990 in Rotterdam, Netherlands. The study was in response to demographic changes of increasing older adults and recognizing that diseases like cardiovascular disease and neurological disease clustered toward the end of life. So this study that I'm presenting used 3 cohorts of the Rotterdam study and used their baseline as follow-up visits within the period of 2002 to 2008. And then they had follow-up about every 4 years. They included individuals over the age of 60, as mentioned, at risk of dementia, and they excluded individuals with MMSE scores less than 26 at baseline. So this led to a number of 5,511. And then for the MRI analyses, they actually used participants, as I mentioned, who were over the age of 45 to account for the long preclinical phase of dementia, compiling 4,912 individuals who had at least one scan that passed quality control. And so first they looked at antidepressant use captured from the pharmacy records for all patients who were included in the study at the baseline. They were essentially available from 1991 onwards until baseline, which we said was about 2002 to 2008. The records had details on prescription date and defined daily dose on a day-to-day basis. The use of antidepressant was defined as any antidepressant prescribed during this exposure period to try to limit reverse causality of medication use for depression due to prodromal dementia. And then secondly, participants were screened for dementia at each visit using the MMSE and the Geriatric Mental Schedule until 2018. So I was familiar with the MMSE, but I had to look at the GMS. Essentially, it's a scale used in geriatric psychiatry, cited as a gold standard in research with good reliability and validity, which has about 100 to 200 questions to assess psychopathology in older adults. Takes up to 50 minutes. And so if either the MMSE or the GMS were abnormal, the participant then underwent further investigation through an informant interview and the Cambridge examination for mental disorders of the elderly. So this basically looks to diagnose and measure dementia in older adults through patient interviews, cognitive testing, and informant interviews with high interrelator reliability, sensitivity, and specificity. Additionally, the entire cohort was under surveillance for dementia through electronic linkage to the GP records and Regional Institute for Outpatient Mental Health Care. So any cases that were suspicious of dementia were then reviewed by a consensus panel, including a neurologist who used the DSM-4 criteria to come to a final diagnosis. And then thirdly, cognitive functioning was assessed at baseline and each visit with a neuropsychological battery that aimed to capture executive functioning and memory. So this included tasks like a letter digit substitution task, verbal fluency testing with animal cues, Stroop testing, 15-word learning test, and the Purdue pegboard test. And they used a composite score, a G factor. And then if data was missing, simple imputation was noted to be used. Then they looked at brain volume with MRI scans throughout the study period, specifically looking at total brain, white matter, gray matter, and areas involved in regulation of mood and memory, hippocampus, thalamus, amygdala. And then finally, genotyping was performed for the, they looked at a genetic risk score as an instrumental analysis, focusing on what they cited as the two most used antidepressants, amitriptyline and paroxetine. Based on the established involvement of the CYP2D6 genotype in amitriptyline and paroxetine metabolism, they included all single nucleotide polymorphisms with a prevalence of greater than 1% in participants of European ancestry and greater than 10% in those of African or Asian ancestry because of the small number of non-white participants in the Rotterdam study. The genetic risk score was then the sum of all present SNPs, and basically a higher genetic risk score would signal slower metabolism of the particular drug, and they wanted to see if slower metabolism was then related to dementia risk. And so I don't have, there isn't access to a protocol for this study specifically, but they have this schematic to help visualize the timeline of the study. Basically, we see baseline is when participants were included in the period of 2002 to 2008. And then that was dependent on which Rotterdam cohort of the three they belonged to. And then they had available pharmacy data dating back to 1991, and the follow-up period beginning after baseline there until about 2018. And follow-up for dementia was complete for almost 97% of potential person years. Table 1 here outlines the baseline characteristics of study participants. So as we can see in the cognitive analysis group, which is the first column, there's a mean age of 70.6, nearly 58% women. Most had some sort of smoking history. 85% had some history of alcohol consumption, and 76% had a history of depression, hypertension. The Center for Epidemiologic Studies Depression Scale, or the CESD, cutoff at the bottom there. The cutoff of 16 suggested risk of clinical depression, and there were roughly 9% and 8% in the cognitive and MRI samples who met that cutoff respectively. And interesting, nearly 50% at baseline had use of benzodiazepines, which can affect memory. Overall, roughly 5,000 participants in the cognitive analyses, 16.7% used antidepressants in the roughly 10-year exposure period before baseline, and 4.1% of those were using antidepressants at study baseline, despite the roughly 9% who met criteria for clinical depression based off the CESD, noted in Table 1. They break down the percentage of use based on drug class, so TCAs, SSRIs, others, and combination. However, it's not clear what exactly the others were and which medications were most commonly used in each class, I think, which would have been important, as we know that different antidepressants, even within classes, have varying degrees of anticholinergic burden. For example, within SSRIs, paroxetine has a higher anticholinergic burden than others. And even in the others category here, where we see 5% were using, something like mirtazapine might have a little bit of anticholinergic burden, whereas something like bupropion would be would not. And so I think that would have been important information to have been made clear. And here are the results of the fully adjusted model, which essentially showed that antidepressant use of any type was not associated significantly with dementia risk. Looking at every use of antidepressant use, for example, had a hazard ratio of 1.14. That's the top value, the top right value, with a 95% confidence interval crossing 1. And this also stood true when looking for evidence of any dose-response relationship by assessing by cumulative daily dose that was more or less than the median use. So I don't actually have information on what the median was. This is true again when looking specifically at SSRIs. And then when they looked at TCAs, they found that every use of a TCA was associated with a mild to moderate increase in dementia risk with a hazard ratio of 1.36, which I could maybe understand because they typically have a higher burden of anticholinergic properties, but they didn't find a dose-response relationship. They did look at combination of antidepressants and did not find any association with dementia risk, but they were limited by the number of cases in that group, so they were unable to stratify by dose or duration of use. The effect estimate was higher for all-cause dementia in current rather than past users, which might again support the notion that depressive symptoms in dementia prodrome lead to increased prescription of antidepressants, reflecting again potential reverse causation. And they also saw that antidepressant use was use associated with dementia risk was broadly similar between those with and without a history of depression. Given there was no explicit documentation of the indication for medication based on pharmacy records, that potentially helps to address that question. So was an antidepressant perhaps used for pain? However, there could potentially still be an element of recall bias there that could come into play. And of note, they had 80% power to detect a difference of 1.4 in hazard ratio for dementia, but this was determined post hoc. So this table here is expanded just to show both models of adjustment that they did. Model 1 adjusting for age, sex, and education only, and then model 2 adjusting for the table 1 set of characteristics. And this also shows the expanded results based on duration of use, so up to 90 days or greater than 90 days. At baseline, global cognitive function did not differ between antidepressant users and non-users. This graphically represents the results of the antidepressant use and global cognition using the composite G factor score. And the change in global cognition here is shown per year for ever and never uses. They did not find that antidepressant use was associated with decline in global cognitive performance over time, and they also did not see a dose-response relationship. This held true when looking at TCAs alone, SSRIs alone, or combination. And then they looked at cognitive tests separately as well and did not observe an effect on long-term performance on the letter-digit substitution, the Stroop test, the animal fluency testing, and the 15-word learning test. They did see an association actually with slowed reduction in performance on the Purdue pegboard test, which was reflective of psychomotor slowing. This shows the MRI volume analysis. So at baseline, again, they noted no difference in brain volume between participants who had used antidepressant medication during exposure and never users. They also did not note any difference over time between users and non-users in change in brain volume of total brain, gray or white matter, or any of the specific structures they looked at, hippocampus, amygdala, thalamus. They found that TCAs and SSRIs separately were also not associated with this. And then for the instrumental variable analysis, they found that a higher CYP2D6 risk score, which would have reflected slower drug metabolism, was not associated with an increase in dementia risk for either use of amitriptyline or paroxetine, even when adjusting for dose and co-medication. And so this brings us to further critically appraise this. I used the CEBM tool for critical appraisal of prognostic studies and integrated key findings from going through the Robbins 1 tool for non-randomized data, risk of bias tool, into my overall assessment. So to start with, this first question here was a defined representative sample of patients assembled at a common point in the course of their disease. I gave this an overall no, because I did find a few issues here, though baseline was between 2002 to 2008, and they looked at patients who did not have cognitive impairment at the time. I felt that bias could have been introduced in a few ways here. Firstly, selection of patients into the study was based on participant characteristics observed technically after the intervention. An MMSE score within normal range could have disregarded effects of antidepressants prior to baseline. And secondly, there's the potential that individuals could have developed neuropsychiatric symptoms prior to cognitive ones at baseline, again, returning to the issue of reversed causality. There were also post-intervention variables that influenced selection that could have been associated with the intervention. So they could have included individuals who were already experiencing cognitive decline related to antidepressant use, and whether that reflected an inception bias. At baseline, they looked at a variety of variables, including severity of depression using the CESD score, with that cutoff of 16, which they adjusted for in their analysis, but this was technically done after the intervention of starting antidepressants. And then finally, the start of follow-up and intervention are not coinciding per se. So we don't also have exact data of when participants started or stopped their antidepressant in relation to baseline. And there's up to a 10-year exposure period, potentially. They could have been on antidepressants for nearly 10 years prior to baseline, or as little as 90 days. And it's not clear whether those still on antidepressants at baseline had been on them for more or less than the 90 days. And so was patient follow-up sufficiently long and complete? Kind of again unclear here. I found a couple issues. So mean follow-up for the dementia analysis was 10.2 years, and attrition rate for that follow-up was only 3.2%, but for cognitive change analyses, only 66% had at least one repeat assessment at follow-up, and only 73% had at least one repeated assessment MRI. For those who did not follow up with the MRI, they did explain that those are most often women, older adults, less educated, more depressive symptoms, higher BMI, more often diagnosed with comorbidities, like hypertension or diabetes. They did not specify characteristics of those who did not complete follow-up cognitive testing, because individuals with severe mental health disorders or cognitive impairment might be more likely to drop out. This may have attenuated association with cognitive decline and brain volume. And as well, further information about the specific medications within each class, as well as what exactly constituted other medications, that other medications category, the adherence to antidepressants, and whether this was balanced or not was not indicated. Were the outcome criteria either objective or applied in a blind fashion? Again, I had some questions about this. So the outcome criteria, they looked at using measurables that I felt were sound to do this, the MMSE, GMS, CAMDEX. But with the genotyping specifically, they were unable to include all potential SNPs, and it's not entirely clear if those were the ones that were tested were necessarily the most relevant. There was potential for misclassification in this analysis, which was thought to be one of the strengths of doing this overall study, and it wasn't applied in a blinded fashion. And then if subgroups for different with different prognoses are identified, did adjustment for important prognostic factors take place. So they did do adjustment, as I showed before. They did a model 1 for age, sex, and education, and then a second model for several characteristics that could increase the risk of dementia. These are the two models here, sorry. And so does this relate to my patient population? The study participants here were a mostly white population. And so I think that was one area where I had pause about whether this could relate to the patients that I see here in Toronto. They were cognitively well. And just thinking of my longitudinal clinic, usual referrals have some degree of cognitive impairment. And then with looking at specifically paroxetine and amitriptyline in the genotyping, though the study commented that these two medications were most common antidepressants, personally in my clinic and what I've seen on service is that these are relatively uncommon antidepressants today. And so overall, I wasn't sure that this study was so helpful for me. I think I'm still experiencing some executive dysfunction around this decision. And so back to this case of this woman, I don't know necessarily that I have enough of an answer from that study to say that it's necessarily safe to continue her paroxetine. And I might, as usual, engage in a risk-benefit discussion and consider, if she still needs antidepressant medication, and if so, if there might be a better alternative, thinking of something that's maybe more less anticholinergic. So overall, in this study, in this cognitively well population, the use of antidepressants was not necessarily associated with increased risk of dementia, cognitive decline, or brain atrophy. In future, there might be a role of looking at more vulnerable populations, potentially in a memory clinic. I think further information, what stood out to me most was more information about the specific antidepressants, their duration of use, more with better sort of stratification and adherence, and looking at a more diverse population as well. So these are a set of references. And thank you to everybody for listening.
Thank you very much, Mercedes, for a beautiful presentation, very clear and articulated many different types of bias. Thank you. Michael has his hand up. Go ahead. You're still on.
I concur.
David.
Excellent
Yeah.
presentation. Very important. Thank goodness for the result. Can you imagine, and I'm going to speak to Carol as well, telling a patient who's deeply depressed and who's 75 and it's only the first time in their life that you're not going to give them an antidepressant because they may develop dementia. So you're telling them you can be miserable until you become impaired.
Yes, yeah.
Go ahead, Carol.
Not being an expert in statistics, thank you so much for all of that. I guess that the things that stand out for me are two. The fact that many people were still depressed in the study is very concerning. That's a pretty good measure of depression that they used. So why weren't they on antidepressants? And again, as you pointed out, people on paroxetine and amitriptyline, those are very old antidepressants. I would say that your patient that you presented initially, 10 years in my practice is probably too short. People who are on paroxetine have probably been on it 20 years. And therein lies the challenge of figuring out what to do about it. And trying to get people off paroxetine is not a fun affair. It is very challenging. They have very bad withdrawal side effects, and it's a real titration nightmare. So I was pleased with the results as well, but I echo lots of the caveats that you brought up about it that make me wonder about the sample and their approach and who these people were.
Thank you very much. Gary, go ahead.
Thanks very much for excellent presentation. Just for clarity's sake, to get into the study and to have your baseline neuropsych, was the initial how you get in the study based on the MMSE score that you had to, because defining people as being, I'm just curious, cognitively intact based on an MMSE greater than 26, as we know, it's incredibly blunt measures. There's many people with an MMSE greater than 26 that are not cognitively intact. Did they provide information based on the baseline neuropsych testing, which is clearly a bit more detailed way of assessing cognition, about how many of those people at baseline that had MMSE greater than 26 and then had the neuropsych testing, actually based on the neuropsych testing, were not, quotes, cognitively normal at baseline? So that's one question. The other is, based on your presentation, it doesn't appear that they used something like propensity scores or other things to try to ensure that the comparison groups were sort of as similar as they could be. And, you know, in studies like this, always the concern, you know, about, I don't know, this population. The results are surprising. I think everyone is feeling a bit that way. So I'm just struggling a bit to try to understand. And certainly, I think we're all dumbfounded about why the commonest antidepressants were amitriptyline and paroxetine. So they're just things about this study that don't feel quite right, which is not a very articulate or intelligent way of criticizing it, but there's something that's feeling a bit off.
That is how I felt at the end of going through this. And I think, like, looking at other studies who tried to look at the same thing, I think they've commonly come across several issues with this topic. But with the MMSE information, they didn't provide further information on your question of like if they had an MMSE above 26. And then they did neuropsychiatric testing. Basically, the inclusion was the MMSE over 26, as you mentioned. And then they either, with the neuropsych testing, they either looked at the MMSE that was abnormal, or the geriatric mental scale that was abnormal, and then that led to further neuropsychiatric testing. So that could have, but that was looking at in the cognitive change analyses as opposed to the incident dementia analysis.
Thank you. We're so blessed to have Carol join our group. She writes in the chat box, I also worry about adverse childhood events and socioeconomic status that might have affected depression rates, antidepressant use for years prior to the data collection.
Mm-hmm.
And perhaps, Mercedes, I can ask you and perhaps the methodologists as well, if we're looking at a randomized controlled trial and they have the null hypothesis, or we accept the null hypothesis, which I think, if I remember correctly, is a type 2 error, then we look for lack of power. When we want to accept or reject the null hypothesis, we look for all these points of validity. And so in this case, Mercedes, do you accept, despite all these methodological problems, do you accept this association?
They did have the 80% power, but that was a post hoc assessment. But with all of those other issues, I don't know that I can say.
It remains a question.
Yeah.
And the other thing I would say is it doesn't seem like the table ones of the comparison groups were actually presented.
Well, I was just going to ask exactly the same thing. I'm not clear, users versus non-users or never users, and my comment about using something like a propensity score to try to ensure that you're comparing apples to apples. I didn't see that table. So how different were these groups? Because
they weren't presented, yeah. It was just the overall sample in the MRI group, yeah.
Yeah.
So thank you. That brings us very close to the top of the hour. Thank you so much to both our presenters, Farid and Mercedes. And Barb has one more comment. Yes, tremendously grateful to Carol for joining so consistently. Thank you, Carol, as well. By way of announcements, the evaluation survey should have been sent to your inbox a few moments ago. So please take the time to evaluate the session and the presenters. And our virtual research day will be held June 13th, 2024. That's a Thursday from 1 to 4 in the afternoon. And I anticipate most of the participants here will also be invited to our summer barbecue, Tuesday, July the 16th. So thank you all for joining the final session of this academic cycle. What a wonderful way to end the year with two great presentations from Mercedes and Farid. And we wish our two other lead residents, Carolyn and Peter, Gabby and Victoria, all the best on their future career. And our exiting fellows as well. I think Nitsan I saw earlier. I'm not sure if Davina is online as well. Thank you. Have a great weekend.